Last lecture of the day before Q&A, and this is a shorter one. This is a 20-minute lecture. About 3 years ago, when we started putting this particular lecture together, we called it Supervision Essentials. Well, I think, all my PA and NP colleagues in the audience know that over the last 3 years, a lot of things have changed. Used to be that PAs were supervised, nurse practitioners collaborated with physicians. Now the terminology is, we're all part of a team-based approach. So if I say supervision or collaboration, think team-based. So obviously, the supervision or collaboration or whatever in the emergency department is pretty unique. Physicians are usually always available, to the PA or the NP, and we may work with different physicians throughout the shifts that we do. Now, many of you who may have been in practice for many years will remember when that wasn't true, where you may have been the only person, the only provider in a rural emergency center, but things have changed. So it's really important to learn how to be part of a team, know practice styles between the types of clinicians that we work with in the emergency center. As well as departments may have varying policies. Many of you may remember over the years that at some point PAs and NPs said you can see any patient except a patient with severe headache, abdominal pain, or chest pain. And some of that still exists, but for the most part now, all three of our disciplines are seeing the same types of patients. So a little bit about PAs in emergency medicine. There's currently 115,000 and plus currently certified PAs in the country. We've had a huge increase in the number of PA programs in the U.S., 224 with about 40 more programs in the queue. About 8,132 new PAs are certified every year. 42% of PAs are female and under the age of 40. 13.2% or about 15,000 PAs currently work in emergency medicine, and about 3% of PAs work in urgent care. You see the number there. The only certification currently available is through the National Commission on the Certification of PAs, where they have a certificate of added qualification for PAs who want to get into emergency medicine and have that certification. NPs, about 234,000. That number changes every once in a while in terms of how you count them. 315 nurse practitioner programs in the country, about 13,000 NPs working in emergency medicine, and the ENP is certified as either an FNP or an ACNP, and the average nurse practitioner is about 49 years of age. I'm not going to go through this graph, but it's very interesting. How many of us have been asked, well, what's the difference between a nurse practitioner and a PA? And I used to have this big, long elevator speech years ago. But now, what the patient really cares about is that they see somebody who's competent to take care of their problems. I usually say, okay, PAs are trained in a medical model and are regulated by the Board of Medicine or a board of PA practice, at least in 5 states. NPs are educated in the nursing model and are regulated by the Board of Nursing, and physicians are educated in medical model and regulated by the Board of Medicine, and all a part of the team-based approach in emergency medicine. So a successful team, regardless where it is, but in this case we're talking about the emergency department, requires trust, communication, evidence-based practice guidelines, feedback, and experience. It's important that we look at the different state laws. Every law has a particular different scope of practice and supervision or collaboration requirements. So it's important that we share that with our physician colleagues in the emergency department. A number of years ago, the NCCPA, the certification body for the PA profession, went out and looked at about 50 PA physician teams out there to find out were there any commonalities in how the relationship between the physician and the PA when they were successful. And what they came up with was these 5 key success factors. These are intuitive: shared priorities, frequent and effective communication, mutual trust and respect, physician accessibility and approachability. I think that's changed significantly over the years. Consistency of the delivery of patient care. So if these are all present in that relationship between the PA and the physician or the NP and the physician, then you can have success in the practice. In terms of supervision or collaboration, the types of occurs in the practice are really threefold. The first one is prospective supervision, and this is writing and reviewing the assessment and treatment guidelines established when and under what circumstances physician intervention is required. So this is pre-information, and this is information, by the way, that we share with practices in terms of being successful in collaborating with their PA or NP colleagues. Concurrent supervision, this is reviewing patients on a real-time basis based on departmental guidelines or ad hoc. This is talking to the physician while you're seeing the patient. And lastly, the retrospective supervision and after-the-fact review of charts. So all three of these things ought to occur in the team-based setting with our physicians. Let's talk a little bit about some payment-related issues. Medicare, I think we're all aware that there are significant issues with CMS, particularly with charting. So, basically know what those are and don't mess with CMS. So for a physician to collect 100% of the Medicare fee scheduled for a PA or NP service, the doc has to personally see the patient, document the medical necessity for the physician's service, and write an appropriate note. If that doesn't occur, then 100% collection payment will not occur. In terms of Medicare for shared services, the physician's NPI number must be on the bill. Otherwise, only 85% of the fee will be paid when the PA or NPI number is noted as the sole provider. Medicaid in most states pays about 100% of its fee schedule, if the patient is treated exclusively by the PA or NP, particularly in Arizona, Alabama, and California. There are some other states that now are electing to pay only 85% when seen by a PA or NP. Private insurance mostly pays 100%. Be interesting to talk to many of you and find out what you're finding in your state, but there's a growing number of private third-party payers who are looking for opportunities to pay less for patients seen exclusively by the PA or NP. Obviously, in dealing with conflict, it's inevitable. As a team member, we all need to have the interest of the patient upmost in our responsibility. Also, physicians need to understand that they are responsible ultimately for the care of all patients in the department. Departmental policy should mandate that a physician see any patient requested by a PA or NP. And I'm sorry we even have to say that. I've been in emergency medicine departments where physicians have refused to see patients that's been seen by a PA or an NP. And hopefully we're getting better at that. Policies regarding when it's required for a physician to write a note on the patient should be really clear-cut in the department. Otherwise, we get into the he said, she said situation, and the lawyers really love that. So we want to not do that. So obviously, this will be interesting. So, we all come from different generations. And in this list, which I can hardly read, but if you look at the different generations of us out there, the GI generation, this is folks that were born before 1936. Do we have any GI generation folks in here and they're able to raise their hand? Nope, okay. How about the silent generation? These are people that are born from 37 to 45. Any of the silent generation in here? Nope. Okay, so baby boomers, that's where I'm at. Okay, 1946 to 1964. How many baby boomers? Now we're starting to see hands up. Okay. Generation X, 65 to 76. Yep. Okay, very good. All right, let's get to our millennials, 77 to 93. Yeah, I expected that. So a majority of millennials. I was going to ask if there are any Generation Z folks in here that were born after 1994, but if you're here, you're in the wrong place. So, and the point here is different generations function differently, in the work site. And there's some great literature out there to look at that. We just need to recognize that. Okay, other things that are must know. Familiarize yourself with the statutes and regulations that govern the scope of practice in your state. I know in the PA world, our professional academy has been working with some model state legislation going from state to state to try to get all the statutes to be fairly, for PAs, fairly the same. As you know, I know the PAs here know that last May here in Vegas, by the way, the American Academy of PAs got together and passed the optimum team practice, and this is twofold. The Academy is going to go from state to state to try to influence legislation to require states to have an independent board, professional regulatory board for PAs. As I said earlier, this occurs in 5 states right now. Arizona is one of them. I happen to be the vice chair of the regulatory board, but the rest of the states either have a subset of a medical board or the medical board itself. So one thing that Optimum Team Practice is looking at is, to start letting the profession regulate the profession, and I think it's time for that. The second thing is, like all professions, we want to be able to function and practice at the highest levels of our scope of practice and our licensure, and so that's what the PA world is doing right now. So it's up to us as PAs and NPs to make sure that we understand the statutes and the regulations that govern our scope. And especially in some states where specific supervision or collaboration rules exist. Be prepared to present the statutes, rules, and regulations to the physicians in your practice or the business manager so that information is available. The education needs to go both ways so that understand the scope of practice. And be sure to review your IRS guidelines for employee status versus independent contractor status. And if you haven't looked up the IRS guidelines, there's a link there for that to determine what's best for you in terms of employer status or independent contractor status. Liability insurance, and I think Dr. Henry talks a little later about malpractice, but I'm here to let you know that I think it's important to find out what type of liability insurance is offered, whether your employer makes it available for you, and then determine whether it's occurrence-based or claims-based, as well as the limits of liability. Find out if your malpractice insurance actually lists your name on the face page, and determine if you have limits or you share those limits with the physician. It's very important to do that. Many places, the practice or the physician may get vicarious liability to cover issues that may occur with you, and if that occurs, what happens is you may not have any say-so in the outcome of the insurance company in terms of deciding to settle that or not. Occurrence-based insurance is usually recommended. If it's claims-based, claims made, find out if tail coverage is paid by the employer or if there's a rider on the physician's policy. And determine if your contract will allow for the cost of the tail to be deducted from final amounts that may be owed to you upon termination. And be prepared to acquire the tail to ensure coverage. The biggest issue that we find in malpractice cases with PAs and NPs currently in the last couple of years, and I've done some expert witness cases, and it comes down to what's called inadequate supervision. One of the most common complaints in medical malpractice cases. In fact, last year I was on 2 cases where a PA and a physician were sued, and somewhere during the process the physician was dropped from the case, and the PA stayed in the case by themselves. So there's a lot of interesting things going on in the area of malpractice issues. Okay, resources. Make sure that, and here's a shameless plug. Actually, I was able to co-author a book a number of years ago called The Preceptor's Handbook for Supervising PAs. This is written by myself, another PA, a MD, and a DO, and it's been utilized throughout the country at educational institutions to look how recommendations for preceptors, both as a student and as a graduate. It's important that I think that we be members of our professional associations and our specialty associations to be able to get the most important information out there for our practice. And I think that was all the stuff that I had. A lot of great things going on, among our professions, and over the next couple of years, the importance of PAs and NPs, particularly in the emergency medicine setting, and legal in terms of scope of practice is out there, so be involved. I would say that the most important thing is show up, stand up, speak up, and know when to shut up. And on that, I'll end. Thank you.